I'm Peter Hersh. I'm here with Dr. Elizabeth Davis to discuss CTAK, or corneal tissue addition keratoplasty, which we are using for keratoconus. What is CTAK? CTAK is a new lamellar keratoplasty procedure designed to improve visual function in keratoconus patients. Notably, it uses preserved tissue from cornea gen. This is tissue that's sterilized by gamma irradiation, and it's devitalized. So the preserved corneal tissue has no endothelium, no epithelium, and the keratocytes are diminished by the gamma irradiation. Indeed, you receive the tissue inlay that can be stored for upwards of 2 years. One thing about the gamma irradiation of the tissue is that it makes it easier to use because it is somewhat on the stiffer side. Now, remember, this tissue is harvested with normal eye banking techniques. Typically, a DMEK graft is taken from the tissue beforehand, so the gift of the donor really is honored in 2 ways. It can be used for DMEK grafts in patients with corneal edema, and the rest of the tissue is preserved and is then processed into CTAK lamellar inlays. CTAK was first originated back in 2015 when we started an IRB protocol looking at the use of preserved corneal tissue in a customized approach to improve the keratoconic cornea. I actually did the first case back in 2016, so we're upwards of 10 years in the development of the procedure. Initially, we used full lenticules that were shaped for an individual's cornea. And we did find that we had excellent topographic results with this. However, the visual acuity wasn't quite up to what we were looking for. And indeed, this was secondary to the tissue interface. So CTAK has evolved along with Cornea Gen and our group with Dr. Stephen Greenstein and Dr. Gelles into a procedure that spares the tissue. So essentially, we started to cut donuts, a little hole over the pupil in our inlays, and it's developed into a pupil-sparing lamellar inlays. Now, importantly, CTAK is customized. It is designed to individual patient topographic and tomographic specifications using a proprietary software program. This defines 2 things. Number 1, the parameters of the tissue inlays, the thickness, the length, the width, and the radius of curvature. These specifications are uploaded to Cornea Gen, and the tissue is cut to the customized specifications using femtosecond laser technology that Cornea Gen has. This is just a brief timeline of the development of CTAK. Again, we're now at our 10-year anniversary since the procedure was first conceived, and now there have been well over 500 cases that have been done in the United States. I'm going to discuss now a little bit about preoperative patient selection. CTAK, especially for your first cases, should be reserved for patients with typical keratoconus. So we like to look for the standard keratoconic pattern on corneal topography. That is, most of these patients have either central or inferotemporal steepening. We like to have the maximum keratometry and the thinnest pachymetry, that is really the center of the cone, for your first cases inside the 6 millimeter diameter zones. So you can see the top two topographies show typical keratoconic patterns that would be amenable to a good CTAK result. Down below on the left, you see a typical corneal thickness in keratoconus. And again, we're looking at a thin pachymetry, a center of the cone within the 6 millimeter optical zone. We like to use patients who have cones between 50 and 75 diopters for your first case. Of course, there shouldn't be scarring in the visual axis because we're looking for improved visual function and visual acuity afterwards. And in your cases, you should make sure that the area of the femtosecond laser channel that you'll be making is more than 300 microns in thickness. And beware of any scarring that you might have in the femtosecond laser track because this could interfere with the femtosecond laser itself. And of course, you want to treat patients who need it. So patients who are corrected to 20/20 and doing well shouldn't have the procedure, but it is amenable to patients with a wide degree of incoming keratoconic patterns as well as visual acuities. For your first cases, you do want to avoid patients with a pellucid pattern keratoconus, as you see on the bottom right here, those crab claw appearances where the cone is very peripheral. Right now, for the most part, we're using the Penacam corneal topography and tomography device. We are expanding this. CorneaGen's working hard on developing new software for other devices as well. But right now, the Penacam is our go-to device for uploading the patient parameters. To develop the CTAK plan, the patient would undergo the corneal topography. This is then sent up via a CTAK uploader that you'll find on the Pentacam to CorneaGen, which then will send back a surgical plan with the proper parameters of the tissue inlay. The surgeon then reviews this plan and makes sure it is to his or her liking and can change the parameters as they like. So it is ultimately the surgeon's selection of the parameters of this customized inlay that they will eventually use. So the recommendations will be corneal thickness and the corneal size and shape. The surgeon then makes a selection, and for instance, by his or her knowledge of the patient might create a thicker segment or a shorter segment, depending on the actual clinical appearance. You will then receive a surgical plan, which will delineate the actual alignment of the corneal segment within the cornea, the axis, as well as the differential from the pupil. Now, let's look at outcomes a bit. We initially published our first cases of CTAK back in the JCRS a few years back. The current study that I'll report on now are 37 eyes of 34 patients done with my co-investigators, Stephen Greenstein, John Gelles, and Fabricio Sanchez. Now, here are the notable outcomes. The one which stands out the most, I think, in CTAK is the improvement of uncorrected vision. We have, on average, an improvement of about 5 or 6 lines. And you can see here that upwards of half of the patients get over a 6-line uncorrected visual acuity improvement. So what one first notices when using CTAK, there's somewhat of a wow effect that patients are seeing much better, and many of them are achieving functional uncorrected distance visual acuity, which is exciting for the patient. And patients, of course, would still need to undergo a collagen corneal cross-linking to prevent progression, but this gives them a really dramatic effect in improving their visual function. Looking at corrected distance visual acuity, we find about a 2 to 3 line improvement. Again, a large number of eyes getting a substantial clinical improvement. Refraction also is improved. Patients typically with keratoconus have higher myopia and astigmatism, and on average we find that the manifest refractive spherical equivalent improves by about 4 diopters. Similarly, we see a good improvement in corneal astigmatism. Looking at topography descriptors, on average, we find that the mean keratometry improves by about 8 diopters. The maximum keratometry similarly improves by about 8 diopters, and the average maximum flattening is upwards of 15 diopters. And depending on the selection of the inlay, we have gotten up to 25 diopters of flattening, so rather dramatic flattening in these cases. What is important to note, however, is not so much what is the maximum flattening that we can get, but rather is the customized approach for different degrees of keratoconus. We want less flattening, clearly, for patients who have more mild keratoconus, more flattening for patients who have a greater amount of keratoconus. So one of the great advantages of CTAK is the ability to have these customized lenticules prepared by CorneaGen to fit appropriately and give the best visual outcome in a given keratoconic patient. Now I want to turn the podium over to Dr. Elizabeth Davis from Minnesota, who will discuss the actual surgical procedure. Liz, please.
Can you hear me? Is this on? Okay. All right. So first of all, I want to thank Dr. Hersh for developing this procedure. I've been doing it for the past 1.5 years, and as he says, it is a pretty remarkable wow factor for the patients. And initially, I started with the most severe cases, and now, as I've become more comfortable with it and seen the results, I have moved to those patients who have a more modest loss of best corrected acuity, 20/30, 20/25. And the nice aspect about it is it is a relatively, we don't never like to say simple procedure, but truly compared to, say, doing a DALK or a PK, it really is. And what you saw in the data that he presented was very rapid. At 1 week, patients have a dramatic improvement in their vision. And then there's some stability afterward, but by 1 week, there's a big improvement in their uncorrected vision. They're able to ambulate around their house. Some can drive, those sorts of things. So really a remarkable contribution. So then we go into how to actually do the procedure. So I'll go to the next slide. Are you able to advance for me? Okay, so you need to, as Dr. Hersh mentioned, for right now, you have to have a pentacam with iris camera in it because it is aligned appropriately to iris markers. But CorneaGen is working on some additional tomography devices. You then, of course, need a femtosecond laser, and these are the compatible ones. We use the F.A.C.S in our practice, but you can even use a LensX, the F.S. 200. The ones that are not compatible are listed: the Catalyst, the LensR, other excimer lasers. And then you need a set of instruments to dissect your channel and also to insert the segment. Okay, next. So these are the instruments that are helpful. Do you need them all? You don't necessarily. You can use some of your own instruments. Corza Medical makes these. However, turns out, and I don't have any financial interest in Corsa Medical, it turns out they've crafted it appropriately so that if you just buy two, it's more expensive than if you just buy the whole set. So you're going to need markers for your offset that is defined for you for the positioning by Cornea Gen. You need your inner optical zone marker. You need a channel dissector. Those of you who've done intacs have that. These, these are nice, the Inlay forceps that they have, because they're curved, but you'll see in some videos I'm using some MST tooth forceps. You can use, this is a manipulator when you're in the channel to advance the segment. Oh, thank you. However, you could use a reverse Sinskey hook for any of you DSEC surgeons and other instruments. And then the Inlay applinator I call it the milker, because it helps milk the segment along. When you put it in, it kind of tends to bunch up. And then with this, you can kind of applinate and push it along. Do I use this to advance? I don't think. Oh, I see, for the pen. Can you advance? Oh, I see. Okay, so procedure steps, next one. Okay, so the procedure, what you're gonna first do is what I like to do. So we start out in the laser suite to make your channel. And the very first thing you're gonna do is mark your offset. So I take the plan, I tape it upside down so it's a surgeon's view, and then I mark it with those markers. You're gonna mark infratemporal, temporal, inferior, infratemporal, and temporal. And so it's gonna be off to your right on the right eye, off to your left on the left eye. Then you take your optical zone marker for the inner optical zone and you connect those 3 points together. Then you swing them over to the femtosecond laser. When you applanate, you want to center on your circle that you've marked, not on the pupil, because these corneas, the corneal apex is descentered from the pupil. It's going to be that leap of faith. Oh, wow, I'm going to have to really move my centration relative to the pupil. But when you come off suction, you'll see that it then looks centered on the pupil. You'll cut, and then, get under a microscope. You're going to, so I'm still doing all this in the laser suite. I will open the channel in the laser suite. And then what we do is we then go to the OR to insert the segment. You can insert the segment, and I have in the laser suite. It's just for billing purposes. You want to get reimbursed for the tissue, you need to go to a surgery center. You could separate this. Let's say your surgery center does not have a laser in it. You could do this, you could do your insertion on another day, but you want to open that channel, because if you haven't opened it and then a few days later try to, then it's going to be tougher. And then insert your inlay, smooth it out. Again, I tape the diagram upside down so I know where the angle needs to start and end. Okay, next segment. So again, here's what it's going to look like, how you're going to mark. So this is the right eye. You're going to mark here, 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 then take your optical zone marker and line it up with those 3 so that you know how to center it. Now, the thing is, you're not going to have offset markers of 2.8, 2.11, 2.8. So I kind of round. I'll use the 2 millimeter, If it was higher, I might use 2.25, etc. Now the Zeiss laser actually makes 2 incisions. It'll make the one that you're told to make the incision. It also makes another incision here in some of these shorter segments, which helps for pulling through. The IFS only makes the single incision. Okay, so you can go to next. So there's an example. You're marking inferiorly, you're marking temporally. You encompass those marks with your optical zone marker. And so you'll see when you're applanating, this looks decentered relative to the pupil, but that's okay. Next. Okay, you can go next, sorry. Okay, so here is, and if you can play that, oh, maybe I can play the video, yeah. Up, go back one, and oh, it just says codec unavailable. Okay. So anyways, it's got it upside down, so it's the surgeon's view. And with the F.A.C.S laser, it's going to make an incision here, and it does concentric ablations here. With the IFS laser, it's going to do it completely around. You can go to the next. And this one, I think, does advance. There we go. Okay, so this is it's made, and now the surgeon is going to initiate the opening of the channel, and then going to use the channel dissector. Now, the channel dissector thickness is thinner than the channel that you want, so you do kind of need to move it back and forth. Otherwise, you're going to have, it's going to be a tight fit putting your segment in. Now, probably the most challenging aspect of the procedure is finding your segment in the little jar they give to you. So I always give my tech, I'm like, okay, you're challenged. Did you find it? And it's hard. It gets stuck on the inside of the glass vial. And then these are those curved forceps, and using it to applanate it around. Next. So some procedure pearls. This is Dr. Ayers, and mostly what he's saying in this video is, again, you really need to make certain that you do a complete dissection. And when he's verbalizing it, you can't hear it here. He tells you that he runs into a little bit of resistance in advancing it, and it's really important to break those adhesions. In fact, in one of his videos, he shows where he actually attempted to insert the segment, couldn't get it past it, stopped, and then redid the dissection. We can advance. Keep going. I think that's just the other direction he does.
Dr. Davis, we have in-text dissectors.
Yeah, that should work fine. Yep.
Those are nicer because you can see the
you can see a lot easier. Yeah. You can go to the next slide. Okay, so the thing here is these segments are slippery little suckers, so be very careful. So I'm using some MST tooth forceps here, and you also want to do kind of a hand-over-hand approach where you hold it there. Otherwise, as you pull out one, the whole thing kind of wants to come out, and then you can advance. You don't have to. You can use a reverse Sinski, or you can use that manipulator to advance it. Now, these particular MST forceps are fine for short segments, but I'll show you in an upcoming video, because it's not curved, when you have a longer segment, it's going to be more of an issue getting it around. And this is that applanator. You can see how it really pushes and extends the segment around. And this is where it's helpful to have your plan next to you so you know how far around this needs to go. If you want to mark it with gingiva, you can. Next slide. So here I have a segment that I want to say it's probably close. This is a long segment. It's probably 330 degrees. So you want to open both ways. And this is where I think in retrospect, any sort of straight instrument is not ideal. And so probably The curved forceps, at least part of the way. For the inferior aspect, it was fine. But then what I do, since it needs to come back around, I first get it a little more than halfway through. I'll applicate it in a second to unbunch it. But then I go around the other direction to grab the side and pull it through, and I'm successful in doing that, but I actually end up dissecting a little more centrally, kind of creating a plane, which again is fine, but then you want to make certain you push the segment back up against the periphery so it's not kind of hooding over the pupil.
In the segment, can it tear?
It can, it probably could. I've never had it tear because it is firm, and it also depends upon the thickness. You know, a lot of them are going to be more 200 microns or so. So I've never had it tear. But your cornea, your incision entry could tear. I've not had that done, but my partner Dave Harden had, and he ended up, because actually in the end, unlike Intacs, you don't put a stitch in the end, but if it tore, you might want to do or put a BCL on, yeah.
Would it make sense for the bigger segments to make another incision and see if
You just don't want the incision overlying where your segment is going, because you don't want it eroding through. Now, if a smaller one, like I said, with the Zemer laser, it does, so then you can pull it out, that, which is nice. Yeah, so that would be. But you'll see in a second here when I go to pull it through the other end, how far around this thing goes. And so, and this, you know, mostly this is under topical, and you can see the guy tends to want to bell up, and so you got to keep telling him to look down. Look, it's not painful at all, obviously, for the patient. But here's what I wanted to show you. Oh, there's still, you can see it's big. I'm going to go around the other way. And now what I'm doing, so I'm kind of now getting into dissecting in that plane. And then once I grab it, I'm able to pull it through, and it comes all the way around. But you want to make certain that you, you know, get all of the, you know, get all of the wrinkles out that you can. Now, some of them, you know, appearance-wise, they're usually quite clear. Every now and then I've had a cornea that maybe had, you know, maybe a little more arcus or things like that, so it might appear a little bit whiter. So there you see, and then in the end I take the applinator and I kind of just push here to push it back up against that wall. All right, we can go to the next slide. And then again, you'll see, just like I said, using the applinator because it bunches up to smooth any wrinkles out, and making certain you're going all the way around to edge angle 2. We can go to the next one.
How do you know exactly where you want it to end up? Like, I mean, if you mark that, I know it's
you can mark it, but I do just eyeball it. Yeah, yeah. In general, you would know if you took also, you know what the plan should look like, because the angle sits around the base of the cone, goes a few degrees beyond the base of the cone. So you could, in your mind, know where it is based upon the corneal topography. And then how far out it is trying to get at the base of the cone, you know, kind of like a belt lifting up a little beer belly. So you should have an idea, you know, yourself in your mind, just looking at the topography, how far it should go around. We can go to the next one. Because to be, should mention, I used kind of before I moved to cornea gen tissue, which I've never gone back since then because they make it so easy. I did use Keranatural tissue, and then I had to plan it out. So I looked at the topography. I said, I want it from here to here, and based upon that, I want this thickness, but then you got to cut your own tissue, and it's less scientific in using the raw data of the Pentacam. Okay, so an aberrant laser cut. So this is something peculiar to the IFS. My technician did something that ended up causing an aberrant laser ablation with a 90-degree incision, which is not where I wanted it. So I was able to, so like what if you lose suction? You can just reapply just like you do in LASIK and cut again. As long as, like we were talking about, that your incision isn't going to overlay where your segment goes through. So you don't want an incision and then have your tissue traveling underneath it, because then you could get erosion through it. We can go to the next slide. So here are some case examples. This is a 1-year-old patient of mine. His left eye had the more severe keratoconus, uncorrected 2250, best corrected 2040, and then at 3 months after, his uncorrected was now 2040. So now he's really functional, and he best corrects to 2020. Still, even with the, so you might say, why did I fit him with a scleral lens still? Because what probably quality wasn't still perfect with the 2020. And so then we fit him with a contact lens in his 2020. So we can go to the next slide. So that was his topography. And then you can see how this is a difference map on the Pentacam, pre, post, and the difference map. So you really get a nice improvement in the curvature. Probably, the patients who get, so the more severe, so if a patient has a very severe steep central cone, you're gonna get a lot of flattening, but you're probably not gonna do a whole lot to their astigmatism because it's all symmetric. Probably the patients that get the biggest improvement and best corrected are asymmetric steepening, because you're gonna have an asymmetric segment. Next. Not going. Try enter. See if enter acts differently. No? Huh.
Generally, how deep do they ask you?
The depth of it is usually 200. Is most are set at 200. If you have a post-LASIK ectasia, you want to make certain that's deep enough. Some people might do an OCT and measure the thickness of the flap and go another 50 to 100 microns deeper. If they're a post-intact, you remove, like I have a patient, their intact segment eroded, took that out, let them heal for a bit. You want to, what Cornea Gen wants you to do is, before you remove the intact segment, send them your Pentacam. So get a Pentacam, send it, so then they can design where the incision will be, so that it's not going to remove, tell you where to make your incision to take out the segment, so it won't overlie where you're going to put your segment.
The intact channel should be much deeper.
It's going to be much deeper, so then you want to go shallow. Yeah, more shallow. Yep. But again, you could measure that on your OCT, how deep.
It tells you on the surgical plan, like how many degrees to make it.
Yes, you'll enter it, you program it all in. Yep, you're going to program in your depth, your 2 angles, or your incision angle on the IFS, and the width, the inner and outer.
And then the last question, so if I make these in my office where my Femto is, then I'm going to go to the OR. You said go ahead and make the channels and open them immediately in the office, like in the...
Yeah, are you going to do it same day?
Probably not.
Yeah, so then you want to open the channel, so you unzip it, and then that's it.
Yes.
Have them take some drops.
You just do that under the
Scope.
microscope?
Yep. I've even done the whole thing in the laser room in certain situations. But yeah, if you got to do it separate days, then just at least open it, because you really got to break those adhesions. Because you remember, you just have, gas fractionation, but you haven't broken the adhesions. Okay.
with corneal thickness, how thin can the cornea be, or not? Should it be at least?
So in the area where you're going to have your segment, it needs to be at least 300 microns. So you want to look at your pentacam, pachymetry map, and know that in that area you're going to have at least 300 microns. Right, 200 mic, yes, yeah, exactly.
That's one of the reasons to be wary of the pellucid patterns.
Yes.
Where you need to be on the slides?
Yes, this is correct, yes. And so this is what this looks like. So you can even, you could see that wide. So here's the person's pattern, so you can see that you're going around the base of the cone, so it's extending, extending like that, and then it's offset infratemporally. Okay, next
Those
slide.
really big ones, like that huge one
Yeah.
you're putting in. If you had cuts at each end, could you not do 2 half segments?
You can, yes, and that's a good question. So you could, and actually, I haven't done that, but others have, and they say it doesn't make a difference in effect. Yes, yep. Yeah, exactly. Okay, next slide. So this is the second one. Another one, just much more severe, just apical steepening, and so basically, we got an improvement from 2100 to 2040. I think on the subsequent slide it shows you as uncorrected. We can go to next slide. And then this, it's a 300-degree segment. So again, in this one, I'm going to get a lot of flattening because it's a 450 microns, a thick segment, but maybe not as much improvement in best corrected because I'm not doing a whole lot to his astigmatism. Next. But you can see pre, post, we get about 22.4 diopters of flattening. And you remember in Intex, what we get 2 diopters? So quite significant in these more severe cases. So you want to, I'm best corrected 2040, uncorrected 2060. So this is a big improvement for the guy. You don't promise they're going to be out of glasses, not LASIK, still, scleral contact lens, but now they can fit easier into the scleral. Yeah.
So have you taken all your post-Intex patients from years ago and say, hey, we got a new procedure, you might want to try this?
Yeah, I mean, it depends upon if they're doing okay, I'd leave them alone. But yeah, if they're not getting the effect or they've got some glare or things like that, then yeah, you could do that. Yes.
So if you have very high myopia and you put a 360-degree,
Yeah.
could you take a minus 15, flatten them out?
You probably would get a significant flattening. Yeah, because you're flattening the Ks. So that should correlate to, it doesn't look as much in this one, but they're hard to refract. But yes, you do. And that's why their uncorrected improves so much, is because their level of myopia goes down.
So if they had a very shallow chamber,
Yeah.
you didn't want to put an EVO,
Right.
could you?
Oh, I see, as a refractive. Are you talking about a normal patient?
Yeah. Well, normal if you're minus 18.
Right, yeah. I don't know. I haven't done, just high myopes normally, but
It's an idea.
yeah.
Have you done it yet?
Yeah.
How did it work?
Oh, no, we've never done that. No, we've never done, no. We've only keratoconic patients. What you do find, one thing that's interesting in that, what you do find is you probably get a more robust flattening with the KC cornea than I would think with a standard cornea, only because it is more flaccid to begin with, so probably, but you have an idea there.
Yeah. Well, and to speak to that point, you can do this in your post crosslink. So say you did years ago a crosslink, that's still not great. You can come back and do this. You just won't get as much flattening because you have, to speak what Dr. Hersh said, more rigid corneas.
So you'd rather do this first, crossing second, simultaneous?
We have found that we have not studied it particularly, but we've certainly done patients who have cross-linking before.
Right.
We've done it concurrently, and we've done it afterwards. Doesn't seem to be a difference.
How long do you wait after this before you cross
Typically, we wait 3 months. Yeah, yeah. That would be our standard. You know, cross-linking does have a little effect on the cone, but we're really looking at an average of 1.6 diopters, and you know, here we're talking about a much more dramatic shift in the topography. So, from the surgical point of view, it hasn't made a difference. That is, it's not more difficult to place the segment, not more difficult to make the channel. And from an outcomes point of view, I don't think that it makes a difference. But I do impress upon the patients that this is not going to replace cross-linking for their progression. You know, cross-linking is to stop progression, not to improve vision. CTAK is to improve their quality of vision.
Yeah, exactly. Yeah, and that's the whole thing, is just, you know, improving the shape of the cornea is what's going to change your vision, not making it more rigid. All right, next, I think we're... So in summary, you know, it's a great addition for our options. I think it's been a game changer, just getting now some big wow effects, particularly at that 1 week. And if you are pushing your cross-linking out further, because as you know, the cross-linking, patients are blurry, uncomfortable afterward. So if you don't want to destroy your wow effect, let them have that first. And in a week, you know, they come back and they're just very, very impressed. You're just such dramatic improvement in their corneal shape. The uncorrected more than the best corrected, but you're still getting improvement in best corrected. You don't want to tell them that they're necessarily going to get out of their scleral lenses, but it's going to be better vision, easier fit. They might, but not to promise that. So really been an improvement for patients, dramatic. I had a patient just the other week. I ended up doing both eyes. He had pretty significant keratoconus. And he friended one of my techs, my tech who was assisting me on Facebook, and immediately at a week was posting, "This is incredible. I can now drive. I've never seen like this in my life." He was just ecstatic. So a real nice game changer. So thank you. Any other questions? I know you guys have a wet lab afterwards. So. Yes, thank you.
Here, buddy.